Welcome, everyone. This is our fifth installment in our Pediatric Hospital Medicine podcast series. I am your host, Dr. Tony Tarchichi. We are here at Children's Hospital in Pittsburgh of UPMC. Let's do our disclaimer. This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. If anybody's new or wants to know, again, I am an assistant professor at the University of Pittsburgh. I am in the Paul C. Gaffney Diagnostic Referral Group at Children's Hospital Pittsburgh of UPMC. That's our hospitalist group. I am also MedPeds trained, just for whatever it's worth, in this podcast that may come out. We have a guest today. I'm very happy to introduce you to Dr. Scott Maurer. He's an associate professor of pediatrics at the University of Pittsburgh, and he is in the Division of Pediatric Hematology Oncology and the medical director of the Supportive Care Program. Scott, say hi.
Hi, everybody. Thanks for having me.
As usual, let's do our disclosures. I have nothing to disclose.
And neither do I.
Now, this podcast, as you saw, Scott is the director of our Supportive Care Program. What we are going to do today is go through the core competencies in pediatric hospital medicine for hospice and palliative care. That can be found under Specialized Clinical Services, and this is from the 2010 Journal of Hospital Medicine. Now, this core competency on the original paper is split into 4 categories: knowledge, skills, attitudes, and systems organization and improvement. We are going to attempt to at least cover all of knowledge and most of skills, and you'll see towards the end why attitudes is somewhat challenging to go over in a podcast, but we are going to attempt to cover as much as we possibly can. For those of you who've listened before, usually what happens is I do a lot of talking, do a lot of research, and go through article after article. In this particular case, that's hard. PubMeding pediatric hospital medicine, pediatric palliative care, supportive care, the overwhelming majority of literature I found is on oncology patients.
That would be accurate.
That's
the largest group that's doing research in pediatric palliative care, would be the oncologists. There is more emphasis on more chronically ill kids, and there is a growing body of literature in technology-dependent children that is coming about.
Okay. Now, Scott, would you mind telling everybody how you came about into hospice and palliative care?
Yeah, I was a pediatric resident at Seattle Children's Hospital and had the opportunity to work with the director of their palliative care program. At the time, I had already been accepted for hematology oncology fellowship at St. Jude Children's Research Hospital and started to develop an interest in hospice and palliative medicine for children in general. At that time, when I got to St. Jude, they were setting up their pediatric palliative care program, and I encountered 2 wonderful mentors, Dr. Justin Baker and Dr. Javier Kane, and received extra training in hospice and palliative medicine during my HEMONC fellowship, such that I was eligible to sit for the hospice and palliative medicine boards. And so I'm board certified in general pediatrics, pediatric hematology oncology, and also hospice and palliative medicine.
So how we're going to do this is I'm going to read off the specific part of the core competency, and I'm going to let Scott talk. So the first one, we're on the knowledge section. It says pediatric hospitals should be able to define the terms palliative and hospice care and describe the similarities and differences between them. It's a good start.
That is a great start. So I think the definition that I've always used to describe palliative care in general is that it's the art and science of providing care that is family-centered and focused on the quality of life of the child. So the goal of palliative care is not just to add years to the child's life, but to add life to the child's years. We like to talk about the both art and the science of it because we want to point out that this is an entirely studyable field, that we can have evidence-based medicine in pediatric palliative care, that we can find better ways to take care of children and keep them comfortable while they're receiving treatment and also at the end of life. And we want to emphasize the point that there's always room for growth and we can get better. There's a distinction, though, between what is palliative care and what is hospice. There are services in the community, home care services, known as a palliative care home care service, and there is home hospice. And it's important to draw the distinction between those two home care services. A palliative care service is generally reserved for a patient, or in this case a child, who would be continuing to receive life-prolonging therapies with an understanding that their life is limited. They can come back and forth to the hospital for admissions and for hospital care, and when they get discharged, they can re-enroll on a palliative care service. The benefit of a palliative care service is that they get hospice-trained nurse that comes out to their home on a scheduled basis to check in on things like symptoms, to work with the parents on any emotional struggles that they're having, and to acquaint them with the type of care they may receive if they were to ever receive hospice care. Hospice care is a full change in philosophy in the way that we're caring for patients. The philosophy of hospice is that we are providing care to the patient where we are neither hastening nor delaying the child's death. We're just focused completely on the child's comfort. That is the only goal, and that is what we're doing. On hospice, the freedom to come back and forth to the hospital for admissions is not really there. So if a child comes to the emergency department and there's an issue where the child would be admitted for life-prolonging measures, that child would need to come off the hospice service in order to do that. Certainly, a patient that's at home on hospice and the parents change their mind and they want to come back to the hospital for either end-of-life care or for further cancer-directed therapy or further life-prolonging therapies, they have that right to make that decision at any time. But they can't do that and stay on hospice the same way they can with palliative care. The benefits of going on hospice care is you have 24/7 access to a hospice nurse. So if that child's uncomfortable at 3 o'clock in the morning, you pick up the phone, a hospice nurse comes out with meds available to help make that child more comfortable. The other thing is, with hospice, you get bereavement care, you get a social worker, you get spiritual care, and the other benefit of hospice is they'll bring medicines to you. So they don't go to parents don't go to the pharmacy to pick up medicines, the hospice brings the medicine to the parent. So those are the differences between a home palliative care service, where you're getting basically a scheduled visit from a nurse who's looking out for things like comfort and discomfort and maybe making suggestions on how to make a patient more comfortable. They still have the ability to come back and forth to the hospital. Hospice is full care, not the ability to come back and forth to the hospital, but they're receiving care that's really comprehensive and allows them to stay in the home.
Now, that was great, and it really is a nice segue into my second question, which is give examples, and this is what I wanted to ask, and I'm glad it's number two. Can you give examples of someone who would be a good candidate for purely palliative care services?
Absolutely. So if you think about a child who has cancer, and perhaps they've been diagnosed with an incurable tumor, and everybody recognizes that it's incurable, but maybe they're enrolling on a phase 1 chemotherapy trial, or they're continuing with palliative chemotherapy that's going to require frequent lab checks or returns to the hospital. That child is perfect for palliative care. They can go be at home, they can get acquainted with a palliative care nurse. The palliative care nurse and the family usually form some degree of a bond. The child's comfort becomes more of a focus in that scenario. And then if the child progresses and needs to come off that palliative chemotherapy, or we decide the palliative chemotherapy isn't working, or comes off the phase 1 study, and the family decides for no further cancer-directed therapy, then we can roll that patient over to hospice. Typically, they keep the same nurse that they had in the palliative care setting, but now they're on full hospice service, receiving the full hospice benefits that I described previously. So that would be a great example of a patient that would be eligible for palliative care. Another example in more of the peds hospitalist realm would be a child who's maybe has had an anoxic brain injury or a traumatic brain injury and is maybe trach vent and G-tube dependent. The parents are continuing to seek hospital care for ventilator-associated pneumonia or urinary tract infections or feeding intolerance, what have you. If those parents are starting to question all these frequent visits back and forth to the hospital, and they're thinking maybe at some point this is too much, we can get them involved with a home palliative care nurse that might help us keep the child at home and maybe do some of their medical care at home. Maybe you don't need to come in for that ear infection that you're worried is going to turn into a pneumonia, or maybe they have some increased trach secretions, and normally we bring them to the hospital and give them antibiotics and admit them for tracheitis. Maybe we can do some oral antibiotics at the very start, and maybe they don't have to come to the hospital so frequently. That's a great case for palliative care that could eventually roll over into hospice should the parents decide that coming to the hospital is no longer in the child's best interest.
What about something like Duchenne's muscular dystrophy, spina bifida?
Perfect examples as well, where you could get a palliative care nurse involved. The parents we try to help the parents understand that this is a progressive, in the case of Duchenne's muscular dystrophy, this is a progressive disorder, and we can get palliative care involved in that scenario. And if the parents decide, we don't want to do a tracheostomy, or maybe the child already has a trach and they're deciding we don't want to come back to the hospital any further, then we can roll that service over into hospice.
Okay.
The one caveat that I would point out is that for children at least, the Affordable Care Act has allowed for a provision called concurrent care, which means that for children 18 and under, they can receive home hospice services alongside of life-prolonging therapies. So insurance companies are required by the Affordable Care Act to pay for both hospice and allow the child to come back and forth to the hospital. Not every insurance company has really jumped on board, and we've had to do some convincing of hospital providers here in the Commonwealth of Pennsylvania. But more and more we're allowing this concurrent care. So this has somewhat obviated the need for palliative care in the pediatric setting, but is still very relevant in the adult setting, and obviously would become relevant should the Affordable Care Act be repealed. I'm being told by advocates in Washington, D.C., that in the new proposals for healthcare, that this Concurrent Care Act is quote-unquote safe, but obviously with the way things are going, that's up in the air.
And is it usually the same company that does both the home palliative care and the home hospice care?
We really like that to be the case. It's not always the case. There are some companies that just provide hospice care, and there are some companies that just provide home palliative care, and there are some companies that provide both. Obviously, it's ideal if we can use the same company because oftentimes you can keep the same nurse. That's obviously the best scenario, but there have been situations where I've had them on a home palliative care program with one nursing agency, and then we need hospice and we switch them over to another agency. Not the best case, but it works just fine.
Now, describe for me, please, why pediatric hospice and palliative care are optimally provided by an interdisciplinary team consisting of a pediatrician, pediatric nurse, social worker, chaplain, home health aide, and any other people you may want.
Right, so this is really about providing total care to the patient. And the founder of the modern hospice movement, Dr. Cicely Saunders, who is in the United Kingdom, who started hospice in general, an incredible woman, she came up with this concept of total pain. And she described that there is physical pain, that there is emotional pain, that there is spiritual pain, and that there is social pain. And that if we are going to treat the whole patient, we need to address each of these aspects of total pain. In the early parts of the hospice movement, this is the way hospice was set up, to have an interdisciplinary care team that involves all of these multiple specialties: chaplains, art therapy, music therapy, child life, respiratory therapy, physical therapy, occupational therapy. That's physicians and advanced practice providers. That's what our interdisciplinary care team consists of here at the Children's Hospital of Pittsburgh. We need to make sure that we are addressing all aspects of the child's life to improve the child's life to the maximum quality that we can. The other thing that we have to make sure is that we're not just providing multidisciplinary. If the chaplain goes in and has a conversation with the family, and then the physical therapist has a conversation with the family, and then the primary physician has a conversation with the family, and the palliative care physician has a completely separate conversation with the family, that's all well and good, but in an ideal situation, we'd be truly interdisciplinary care, or interdisciplinary, which means that we are all communicating with each other in a way that we're providing a unified message to the family. So we want to draw a distinction between multidisciplinary, which involves multiple services giving individual advice to the family, and interdisciplinary, which is where we're all talking to each other and providing a unified message to the family.
And that's ideal.
Yeah, and that's the most ideal setting. So any hospice is going to have an interdisciplinary care team, and that interdisciplinary care team is going to, at minimum, involve a social worker, a chaplain, a physician, and nursing support. We add all those other supports at our IDT because we have those resources. But at minimum, that hospice is going to meet with that IDT on a weekly basis.
You answered my next question about multidisciplinary versus interdisciplinary. Describe what a decision related to foregoing potentially life-saving or life-sustaining treatments or the withdrawal of life support are often best made before a child becomes ill. So why make the decisions before they become ill? What have you seen?
Right. So, I feel that when we get the consult of there's a child who's who's met brain death criteria and we need to take them off the ventilator, can you come help us, is often less helpful because you're dealing with a family who's in a grieving situation. They're not really interested in meeting new people at that point, and we have zero ability to form a relationship with that family. The other thing is people tend to panic at the end. Are we doing the right thing? Are we is this too soon? We haven't talked about this. We don't know where the family stands. It's just a mess if you wait until the last minute. I talk about decision making in any setting for a child who has a serious illness in a sense that we have to understand it in the context of the goals of care. So any decision we make for a child needs to be explained within the context of our goals for that child. And in order to understand goals for a child, we have to take a step back, and that is to understand, what is this child's prognosis? Is the family's understanding of the child's prognosis congruent with the medical team's understanding of this child's prognosis? And if those two things are different, how do we rectify that? We also want to know, what is the family hoping for? And Chris Feutner wrote a wonderful article in the New England Journal of Medicine, I think back in 2010, where he talked about identifying families' hopes, and he encourages the clinician to continually ask, what are you hoping for your child? And then when the family tells you something, I'm hoping for a miracle, thank you very much for sharing that with me. What else are you hoping for? And what else are you hoping for? And what else are you hoping for? So we can understand that parents may be hoping for a cure. In fact, they're all hoping for a miracle or for a cure. And you know what? So am I. But how do we help that family expand their portfolio of hope? And how do we help them understand that we can hope for more than cure? That we can hope for their child to be comfortable, that we can hope for their child to live to Christmas, that we can hope for their child to live to graduation, or whatever their goals are. What are you hoping for? And then a completely different question that sounds somewhat similar is, what are you expecting? So a family may tell you, I'm hoping for a miracle, Tony. And then you might say, well, what are you expecting? Oh, I know he has progressive cancer and the doctors say he's not going to live another, 6 weeks. Okay, if you had stopped at just what you're hoping for, you might be like, those families delusional or clueless. But if you ask them what they're expecting, they can give you a sense of what they're preparing themselves for. So I always ask those questions. And when we understand the hopes, expectations, and prognosis of a patient, we can then help family pare down things into goals. And families will name goals in any number of different ways, but when you break it down, there's a goal of cure, there's a goal of life prolongation without regard to quality of life, there's a goal of life prolongation with heavy emphasis on quality of life, and there's a goal of comfort only. And if we understand which of those four goals a family is fitting into, then we can look at a decision like, should we place a G-tube? Well, if you take that decision in a vacuum, a parent might say, well, if we place a G-tube, my child will live, and if you don't place a G-tube, my child will die. And so they're choosing between life and death, and what parent can do that? But if we look at that same decision within the goals of care, maybe we can make that a little easier. So if a child has progressive cancer, and we know that they have a terminal prognosis, and the hope is that we can prolong that child's life, provided that child has a good quality of life, then I have to ask myself, okay, what will a G-tube provide us? The G-tube will prolong this child's life. Are we prolonging a life of good quality, or are we prolonging a life of poor quality? And now the decision for the parent is my child suffering or is my child not suffering? And am I prolonging that? A parent can make a decision for comfort versus prolonging a life of poor comfort. They cannot make a decision for life versus death, and we shouldn't expect them to. It's an illusion that we can allow parents to choose between life and death. We can't make that choice. What we can make is a choice for what their life is going to look like. And you can draw that same analogy for a child who is maybe born with lissencephaly or trisomy 18. If a G-tube is on the table or if trach vent is on the table, then we need to understand the goals of care. If the goal of care is life prolongation without any regard to quality of life, then the decision's easy, place the G-tube. If the goal of care is prolonging a life of good quality, then we have to say, is this child suffering or not? Are we, by placing this G-tube, are we going to prolong a life of good quality or are we going to prolong a life of poor quality? And when you frame the decision in that context, parents have a much easier time of making that decision.
Can you get a parent to this point in one session, or how long does it take?
No, you really have to build rapport with a family. On our palliative care service, we follow patients for an average of over 500 days. This is a lot of time and investment. It is a lot of building a relationship, and sometimes families may make what we deem to be unrealistic choices. And we could put our foot down and say, no, this is ridiculous, you can't do this, and the result of that is going to be, thank you very much for your time, I never want to see you again. Mm-hmm. And so we have to ask ourselves in those situations, am I more helpful if I stay involved, or am I more helpful if I'm not involved? I tend to think the former is true. Mm-hmm. And so in the families that make decisions that I don't necessarily think are realistic, my response to that is to get closer to that family, to hang in there with them, and to recognize that Rome wasn't built in a day, and I need to build trust with them.
So now this brings up another point, is how do you recognize your own bias or perspective when you don't agree with the family? Mm. How do you get yourselves to do that? If a family wants life prolongation therapy no matter what for a trisomy 18 patient, mm-hmm. and it's not going to happen, how do you do that as a clinician?
It's really, really hard, and I think as I have matured in my career, I've become better at this, at not being so judgy. One of my colleagues in the field, Robert McCauley, has written a article in the Journal of Palliative Medicine, I believe from 2009, where it's entitled, "When Patients Make the Wrong Decision." And it talks about this very topic of how we introduce our own bias. What I talk to our resident learners about when a parent is making a seemingly unreasonable decision is the first thing that we should say is, why is this mom so, we should not be asking, why is this mom so crazy? What we should be asking is, why is this perfectly reasonable woman making an unreasonable decision? That should be the first line of things. And we need to ask ourselves, does the family have all the information that they need? Does the family understand the information? And if the answer to that is no, then we've got a communication problem that perhaps we can solve. If the family has heard everything that's said and they just are choosing not to believe it, that can be very anxiety provoking for the clinician, right? I tell our learners we need to at some point divorce ourselves from the decision that the parent makes. I view my role as making sure that the parent has all the information they need to make the best possible decision for their baby and for their family. And that I can't place stock in choice A or choice B. My job is to help them get to that point and then to support them in their decision. And if they make a choice that I wouldn't necessarily make, I have to stick in there with them. Eventually, in the case of a patient who has progressive or incurable cancer or Duchenne's muscular dystrophy or trisomy 18, eventually something is going to happen with that child that is going to be either a terminal event or a serious event at least. And I want to make sure that I'm there to support the family when that happens, so that I can look at them and I say, you know what, we really are at the end of the road. It's hard. It's a natural tendency to think, yeah, we know better. Mm-hmm. I've come to realize that maybe I don't know better. I have 2 children of my own. Thank God they're healthy. Mm-hmm. Can I say what I would do if I were in these parents' shoes? No, I can't. I can say what I think I would do or what I hope I would do, but I don't really know what I would do. And, I think that we owe it to our families to hang in there with them. Eventually, these things tend to work themselves out, and if we maintain a good relationship with them, then we're much more helpful.
So, okay, so just so you all know who are listening, I'm skipping around a bit. When Scott gives me a good opening, which he has, I'm moving to attitudes or skills. So we're going to cover everything, and I'm checking it off as we go. So now discuss the elements of a treatment plan for relief of suffering, like appropriate consultations, like palliative care, pain, physiatrist, whoever, and therapies, complementary medicine, pain meds, etc. Give me the elements of a good treatment plan.
Right. So I work within a model called the individualized care plan model, which is where we do a full needs assessment, symptoms that are concerning emotional, social, emotional, and spiritual needs that the patient has, any sort of rehabilitation needs that the patient might have, any sort of bereavement needs that the family might have, and identifying what those needs are. And then from that, identifying the prognosis and identifying the goals of care, and then making decisions that help address those needs that are congruent with that patient's goals of care.
Now, when you say there's social, emotional, spiritual needs, what do you mean?
Yeah, what do I mean about social, emotional, and spiritual needs? So, we take a pretty detailed social history with this family, and I take a spiritual history with each family that we meet in order to make sure that we're addressing, again, that concept of total pain. And so there may be some degree of guilt that the mother or the child feels about the diagnosis. Should we have caught this earlier? If only I had been watching him more before he fell in the pool, whatever. Is there some stumbling block that is preventing us from making good choices for this child or providing good care to this child that has a psychosocial element to it? Social needs. Who's the decision maker for this child? Are the parents together? Do the parents make decisions jointly? Does one parent speak and the other parent just goes along with it? Are the parents separated? Are there custody issues? Are there legal issues? Is this child a ward of the state? Do we need to be working with, Child and Youth Services as the decision maker for this child? Those sorts of sort of concrete things. The other thing is just identifying concrete needs that the family has. Do they have transportation issues? Oftentimes in the setting of chronic illness, parents aren't able to work. How can we reduce those burdens for that family? How can we reduce financial burdens? And then from a spiritual standpoint, I'm really glad you brought this up because this is a point of research for us here at Children's Hospital of Pittsburgh, is thinking about taking a spiritual history for our patients. Many of our learners and even attending physicians shy away from this, maybe don't feel that this is part of our role, maybe feel it's none of our business, but a spiritual history is actually very simple questions. Are faith or spirituality something that's important to you? Are you a member of a faith community that is supporting you? And are there things that I can do to help you with any spiritual pain or spiritual needs that you may have? Can I refer you to a chaplain? Is that something that would be helpful to you? Sometimes you get to question one and the family says no, and then I just move on. Sometimes they say, oh no, my faith community is taking care of me. Sometimes they say, oh, I go to church, but we go every, Christmas and Easter or whatever. Or they may say, I'm not very religious, but I would really appreciate it if someone from your chaplain service came by. Very simple thing to address, very simple questions to ask, and we did a research study right here at Children's Hospital of Pittsburgh which showed that even families who don't identify themselves as religious are not offended by you asking them if they rely on faith or spirituality to support them through this.
Would you advocate this for every patient, our bronchiolitis, our gastroenteritis, or is this patients that we're going to call you on?
I feel that taking care of the whole patient is part of just good clinical care. And so I would advocate that this is a very simple portion of the social history that can be taken on any patient.
Now, explain how the elements of palliative treatment and curative treatment may simultaneously occur during the course of a child's life-limiting illness. And you alluded to this earlier. So this is if a patient, let's say you have them at home, or for us, they're in the hospital, they have palliative services. How does that work? How do we decide, do we do anything? So chest tube, surgery, etc., even if it's not necessarily done for pain management.
Right.
So if you have someone with pleural effusion that can't breathe, you put a tube in, now they're breathing easier. But if this is more for experimental therapies, chemo, whatever.
Right. So I think, again, this all goes back to the goals of care and what are the patient's goals of care, and have we established the goals of care? If a goal of care is comfort only and a child has a pleural effusion, then I would ask, is the child suffering from this pleural effusion? Am I able to manage this with medications, or would this be better managed with, say, a Pleurax drain, which is a permanent drain that can be drained ad lib at home? So the patient has some respiratory symptoms, we hook up a little vacuum tube to their catheter, it drains the fluid out, the patient feels better, boom, you're done. So I think that it all goes back to the patient's goal of care. The one point that I'll make about this is sometimes people would say to me, Scott, you're an oncologist, you must really disagree with phase 1 chemotherapy or experimental chemotherapy. My answer to that is absolutely not. The only way that we have made strides in our field, in any field in pediatrics, is that we've had a dedication to discovery. What I'm hoping that I can convey to people is that our dedication to discovery can live alongside providing care and quality to that child's life. We can manage a child's pain while they're on phase 1 chemotherapy. We can be talking about goals of care while they're getting, upfront chemotherapy in a patient who, say, has a very poor prognosis but a chance of cure. We can be working with a spinal muscular atrophy patient whose parents want to try this new experimental drug that's recently become available. We can work alongside that. And the two things don't have to be mutually exclusive, and I think that's the point of the learning point there, is that palliative care does not have to be mutually exclusive with intent to cure. We just we measure our outcomes in a lot different ways. If you're measuring your outcomes on a cancer-related therapeutic trial, then you're measuring mortality rates and morbidity rates and pain scores and things along those lines. If you're measuring quality of care, then you're looking at things like, how well have you communicated with the parent? How well have you communicated with the child? Are you doing things in a developmentally appropriate way? Those things are much harder to measure than simply mortality rates. But our point is that we can all live together and coexist.
So you've been talking a lot of the stuff what you're discussing, to me, comes off as you're building a good relationship with the patient. That's one of the foundations of everything.
Absolutely.
As a hospitalist, the problem is we may have just met the patient.
Right.
And now we're in their inpatient care. A great example is if a patient's on hospice care. And it's hard to look at it from the University of Pittsburgh because we have you and we have your team and they're always around. But especially from a smaller institution where they may only have one or an adult, and that's another question which we'll get to. But in terms of how would this occur in the acute setting and the hospitalized setting, if you're the hospitalist there, how do you build that relationship? And I guess that comes to, how do you communicate bad news effectively and provide opportunities for families to be introduced to palliative care when it's appropriate in that acute, my name is Dr. Tarchichi and meeting you for the first time?
Right. Yeah, no, it's an interesting challenge, and I think it goes back to something we talked about earlier. Obviously, earlier involvement of palliative care is better, but as a hospitalist, if you're on your own, or even if you have a palliative care specialist, you still have to form a quick relationship with that family. And I think that starts with listening. We have a saying in palliative medicine, don't just do something, sit there. Sometimes it's pulling up a chair and saying, help me understand what the other doctors that have been taking care of your child have said to you. Letting the parent talk. That's a parent that understands that you are listening to them, that you are willing to hear them out, is much more likely to trust you in the long run if they feel they're being heard. And so I think that's kind of how you're able to quickly form rapport with families. I will say that there are like I mentioned earlier, we tend to know our patients for a very long time, but there's a family that we've known for 3 days that we are talking about redirecting care and taking their child off a ventilator at this point. So you can quickly build rapport with people if you need to. Getting into the idea of giving bad news or helping patients create goals of care, I think again it comes down to listening. I always start a conversation with a new family by saying, help me understand what the doctors have said to you. Or what have the doctors said to you? that gives me an idea of where they are and what they've heard. A lot of times people are like, this family's clueless, and I'll go in and say, what have the doctor said to you? And they'd say that this is incurable and she's gonna die. I'm like, okay, so not so clueless. And 9 times out of 10, that's exactly what happens. When you're communicating bad news, you wanna make sure that you are in an environment that is conducive to giving bad news. So many people talk about the spikes model, thinking about the setting, asking for permission, etc. There are various publications about this model. What we try and help families do when we're giving bad news is I assess their understanding, and then I tell them, I hear what you're saying. I have some new information that might help get us further along in our understanding of what's happening with your child. And I pause. And the family then would say, okay, well, what is it? So I've asked for an invitation to continue talking. And I would say, his scans today show us that this pleural effusion has reaccumulated, and we're not going to be able to get your child off of the ventilator. And then I stop talking. And the most important thing when you are giving someone bad news is to stop talking. I always tell the residents a good day at the beach is when the waves come in and the waves go out. A bad day at the beach is when there's a tsunami. Mm-hmm. And if you just keep talking, that is a tsunami of information. And the parent is going to not hear you, and it's going to go very poorly. If you stop talking and you wait for the family to then respond to that, what do you mean he's not going to come off the ventilator? I thought that this chest tube was going to fix everything. Then you know where the direction's going to go. I talked to this with our pediatric residents and also our hematology oncology fellows when we're doing a day 1 talk. I've had a chance to look at your child's blood smear underneath the microscope, and unfortunately, I have to tell you that your child has leukemia, which is a form of cancer. And I stopped talking. I want to put the ball in the parent's court so that they have some semblance of control over the pace of that conversation and where that conversation is going. If I started saying your child has leukemia and we're going to give 4 weeks of induction therapy and 8 weeks of consolidation therapy, and then depending on what his MRD is, then we're going to decide what's going to happen next, and we're going to go into term maintenance, and the whole therapy is going to take about 3.5 years, but you know what, I'll be here with you. They have heard none of that. It's way too technical. We have to stop talking. And so I always say, stop talking, and then the other thing I want people to remember is to both expect and respond to emotion. A family may say to you, for their child with perhaps, say you're a hospitalist and you have a kid who has a static encephalopathy, maybe from some anoxic injury at birth, and maybe they're 9-10 years old and they're here with chronic aspiration pneumonia, and the kid's teetering on going to the PICU for the umpteenth time, and you know that they're going to start talking about trach vent and all of this sort of stuff with them. You may say to them at that moment, I think we're headed down to the PICU, and I think that moment that you may have talked about with other doctors about him needing to have a tracheostomy and perhaps ventilation is coming. You might get a response of, what do you mean? Give me a doctor in here who can actually tell me something that I want to hear. To get somebody in here who knows what they're doing. You could respond by saying, I didn't mean to do that. I can get my supervisor. I can get another physician. We can get a second opinion. Or you could respond to recognize this as emotion coming at you, and you could say, this is really hard. Do they really want a second opinion? They may, and you may get to that. But in that moment, they're responding with an emotion. I'm sorry to tell you, your child's cancer has come back, and we do not have the medicines we need to make your child better. I want to see the division chief in here. I want you to call another hospital. This is really hard. I wish I had better news. It's the same thing as, I always give this analogy to our learners. If my wife comes home and tells me, my boss is such a jerk, he called me into the office and he said that he didn't want the report written this way and blah, 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 blah. If I say to my wife, did you think about talking to your boss beforehand about the expectations he had for this report? I'm probably going to be sleeping on the couch that night, right?
Yes.
But if I respond with, gosh, what a rough day. That sounds terrible. He had no right to speak to you that way. I'm going to get a much better response in that environment. The same thing is true when you're giving bad news to parents, is expect that they're going to respond with emotion and respond to that emotion. Don't say, I can understand how you feel, because that's going to get you in trouble. But just say, I can see that you're angry. You have every right to be angry.
Do you need to identify the emotion?
Sometimes I name it. Yeah, we talk about this nurse mnemonic where we name the emotion, we express understanding of the emotion, we respect the emotion, and respond with empathy. There's a great website called oncotalk.org, oncotalk.org, where we talk about this nurse mnemonic and relaying bad news to patients. It's a really great website and a really great resource.
Now, flipping it a little bit back to our role with you, so for those of us who have, like at Pittsburgh where we have you guys as a palliative care, how do you see your utilization, but more than that, how do you want to be introduced? Answer that in whatever order you like. Meaning, before you've met the family, I've met the family, and I've decided, I think I need to get palliative care to help with this case. How would you prefer I make that introduction to them that I'm calling you?
Yeah, so we deliberately call ourselves a supportive care team, because that is what we're there for. We're there to support a family. People hear the word palliative care and it's a charged word. People are like, oh, that's end-of-life care or hospice care. That's not what we're in. That's not what we're here for, so we don't want that. So what I prefer that people would say is, we have a team of doctors and nurses that are here to help support families whose child is seriously ill. And I'd like to bring them in here to see if there are ways that we can better manage your child's symptoms or better help you as you walk through this journey. That's the best way. I always say we call ourselves a supportive care team because we're here to support you. In whatever form that looks like, we're here to support you. And I feel like that has given us a good foot in the door with these families.
I think that was great. Now, for those who don't have a palliative care person on site, first of all, if you're in a small hospital connected to an adult hospital, do you think an adult palliative care specialist would or could step in to assist in a case?
I think absolutely an adult palliative care specialist could be very helpful. I think especially from the aspect of communication and setting goals of care. I think you would have to be, as the referring physician, you would have to be very clear what you wanted from them, and you would probably have to help them understand the medical facts and the prognostication difficulties that exist in pediatrics. The adults, they have these very set tools that they can judge a patient's prognosis based on their ejection fraction or based on how much Lasix they're using or what kind of support they're needing, where they can pinpoint very accurately a patient's life expectancy. In pediatrics, we do not have that. We deal in a lot of prognostic uncertainty. A child has a genetic defect that only 3 kids in the world have ever been described as having. We have no idea what this means. We deal with a lot of prognostic uncertainty, which makes our job a little bit more difficult. And so I think helping that adult provider recognize that there is prognostic uncertainty and we need help with symptom management or goals of care and being very clear about that. The other thing that I'll say is that an adult provider can very much help you with ideas for symptom management, but as the pediatric hospitalist or as the med-peds hospitalist, you would have to help them understand how to appropriately dose those things, because adult trained physicians don't always understand dosing in children, or they're afraid of it. We have all of the every adult hospice and palliative medicine trained physician who has gone through a fellowship is required to do a pediatrics rotation. And so we have access to our fellows here at the University of Pittsburgh. And what I try to convey to them is that the communication skills are universal and that the rest is dosing. And so I try to help them understand that, yes, they can be helpful in a pediatric case. So everybody just needs to take a deep breath. Yes, the patient is 8, but our communication principles are very, very similar.
So that brings me to a point when you talked about dosing and the medication. So do you want the hospitalist to be comfortable? So let me give you where this is coming from. On my adult training, when we trained with hospice and palliative care, and in New Jersey I had a significant palliative care experience on the adult side, we would carry around the morphine, we would dose the morphine, we would dose the Ativan if needed. We got some guidance from our palliative care group, but we did the work. On the pediatric side, I don't think it's exactly the same.
I was just having this conversation with our MedPeds fellow, who's a hospice and palliative medicine fellow who's MedPeds trained. And, in pediatrics, people are just more territorial and hands-on. I say that as a pediatrician and as an oncologist. We oftentimes have to ask for permission to do various things that we're doing. I think that the history of pain management in pediatrics is also at play here. In 2001, the thing that started the whole movement of palliative medicine in pediatrics was the Institute of Medicine issued a pretty scathing report about the state of end-of-life care for children in this country. And one of the major holes was deficiencies in management of pain and other symptoms at the end of life. And as pediatricians, we were doing a terrible job of this type of management. I'm pleased to say that in a very short period of time we have turned this card around, but there are still pediatricians who are very afraid to provide pain medications in adequate doses to children. And so part of our role and as a pediatric palliative medicine physician is to help empower people to actually treat pain and adjust and titrate opioids in an appropriate way, the same way they would do in, say, an adult patient. But the same principles apply to pediatrics and not being afraid of opioids and pain management, especially for children who have a life-limiting or terminal illness. So ideally, I would like the primary team to be in charge of the pain plan and managing the pain plan with assistance from us. In practicality, I think that many people are uncomfortable with management of patient control analgesia, with thinking about the different formulations of morphine or oxycodone that are available. Like, really? There's a sublingual version? Absolutely. Oh, you don't need an IV to take care of this neonate with maybe skeletal dysplasia that we need to provide end-of-life care? No, we don't need an IV. We can do all of this. So part of it is on us in palliative care to empower people to actually take care of these issues, and the other part is for the other side to come up and take the initiative.
So what about for end of life, in terms of the patients? We had a couple of cases where the patients come into the hospital because of parental anxiety, parental fear. Do you feel the hospital should take more of a role in terms of giving the medicine, dosing the medicine at the patient's end of life? Or do you feel that pediatric palliative care specialist is really best for this? Or should it be a collaborative effort?
I think it's best as a collaborative effort. I mean, there aren't that many pediatric palliative care providers in this country. I hope, thankfully, there are more and more. But we can't be at the bedside 24/7, and we are a consultative service. I think it is best if we come up with a pain plan with contingency plans, or a comfort plan with contingency plans for our patients, and that we are communicating that well with the primary team taking care of that patient, so the hospitalist service, and making sure it's on me to make sure that our hospitalists are comfortable carrying out this plan and that we've come to this plan together. And then it's on the hospital team to be able to adhere to that plan and know when to call for help. I think it's best as a collaborative effort.
Now describe with a process involved in writing an allow natural death, A&D orders, pronouncing someone dead, completing a death certificate, autopsy, donor mandates and options, and accessing immediate support for family caregivers staff.
Yeah, absolutely. So I want to make very clear that an allow natural death order, or a do not resuscitate order, or a do not attempt resuscitation order, however you want to term it, is not a goal of care. A lot of times people see, the patient has a DNR, or the term that I actually bristle at is he is a DNR. A DNR is an order, not a person. A DNR is an order, not a goal. A patient can have a goal of cure and have a do not resuscitate order, meaning all it's saying is if a patient's heart stops beating, don't do CPR. That is what a do not resuscitate order is. Just like Lasix 20 milligrams Q6 hours is an order. So I like to make sure that we draw a distinction between an order and a goal, and this most certainly is an order. So whenever you are talking about a do not resuscitate order, just making sure that you're understanding it for what it is and what it isn't. I always talk to families, and I feel like when we're talking about do not resuscitate orders, we should be giving the family a recommendation. If I have a child with widely metastatic cancer that is progressive and incurable, I know that if that child suffers cardiopulmonary arrest as a result of their tumor, that coding them is not going to be beneficial. And so I should say that to the family. And what I will say to the family is, if your child's heart stops beating or they stop breathing as a result of this tumor, I know that doing CPR and doing chest compressions will only cause your child harm and will not change the outcome of this. For that reason, I think it's best if we protect your child from things that are not going to be beneficial and have an order in place that says we're not going to do those things. I'm making a recommendation. I'm not asking the family, do you want this or not? It's not like ordering a pizza. We want to make a recommendation and say, do you agree with me or do you disagree with me? I shouldn't be in a position of asking a parent to make that decision. That's how I would say a do not resuscitate order. Every state has its own laws. Every hospital has its own policies. Here in the state of Pennsylvania, we have we're a POLST state. So it's physicians' orders for life-sustaining therapies is what POLST stands for. There is a legal document. That legal document in the Commonwealth of Pennsylvania is only valid for 18 and older. So we write at-home DNR orders for our children in a separate way. And that varies state by state. And so you would want to ask people in your state, what are the rules in your state regarding a do not resuscitate order? When a patient dies, there are a number of different ways of doing this, but I get notification from the nurse that maybe a patient is now apneic and they want us to come and announce the patient. I walk into the room. Hopefully I have met them and know them. At this point, if there's a patient who has a goal of comfort only and a do not resuscitate order that's on your service, I would advocate, if you're covering for the night or if you are just the daytime physician or whatever, that at the start of your shift you go in and introduce yourself to the family. I'm here. If your child is uncomfortable, I will come. Please just let me know that you can call me for anything. That way you've at least established a relationship with the family. When you get called in, I walk in the room and I say to the family, usually they're in quite an emotional state because they've noticed that the child has stopped breathing. I say, is it okay if I check your child? They all want you to. I directly auscultate the heart, I feel for the carotid pulse, and I look for spontaneous respirations. I do that for about a 1 to 2 minute period. If I find none of those things, I look at the family and I say, I'm very sorry to tell you, your child has died. And I use the D word. I use died. Passed, gone. These are all euphemisms that in a distressed emotional state may be misunderstood. And I always say he has died. I used to think it was cruel to declare the time of death, or maybe melodramatic to declare the time of death, and so for years I never did, but I will tell you that almost every family has said, what's the time of death? And so I will now say to families, we will call the time of death 6:32. And the families seem to respond to that sort of finality of that statement. I found that if I don't mention it, I am eventually asked what was the time of death. For some reason that matters to many families. I then write a note in the chart that says I was called by the nurse to come after the patient was noted to be apneic and asystolic. I met with the family. I directly auscultated the heart, felt for a carotid pulse, and observed for breathing. After X amount of minutes, I found none, and I declared the patient dead at X amount of time. Filling out a death certificate is very, very different depending on what state you're in. Sometimes the forms are very short, sometimes the forms are very long, sometimes you have to type them, sometimes you handwrite them. I would encourage any provider to look at the death certificate. Oftentimes, your Department of Health in your state will have instructions on how to fill out a death certificate, and I would advise you reading that. Sometimes your palliative care physician or your hospital team has very nicely provided you a copy of a death certificate and highlighted the areas that you need to fill out so you don't have to look for this information each time. All of those things are very helpful in filling out a death certificate. The one thing I'll say that's universal is that filling out the death certificate should be something you do quickly, and that the death certificate in most states needs to stay with the body at all times. And then support of the caregivers and family after. I always tell families we are not on a timeline. You can stay with your child as long as you need to. I try to restrict barriers that are preventing the family from being with the child. If they want to get in bed with the child, I pull down the bed rails and get them in bed with the child if they want to hold the child. that's fine. And if there are any rituals that they need to perform, I make sure that we've provided them the ability to do that. And then here at Children's Hospital of Pittsburgh, we have a bereavement coordinator and a very well-structured bereavement program. Even small hospitals can create a bereavement program that at least follows up with the family or sends them resources or is willing to find them mental health resources in their community if they need grief support. If a child has been enrolled on hospice, they automatically get bereavement support. The family will get bereavement support after the death of the child. I think it's important to recognize that most hospices are going to be geared towards the death of an adult as opposed to the death of a child, and that trauma is significantly different. But if you are in a smaller community and you're not sure what grief and bereavement resources are available, contacting a local hospice in your area may be very helpful in identifying what resources are available. Hospices have social workers that will have access to grief and bereavement resources, and asking to speak with the social worker at a hospice in your community may be very helpful. The other thing is to call your children's hospital that you refer to. If you're in a more rural area, but you send patients to a large quaternary care center for pediatric care, chances are that place has a palliative care program, and contacting them and using that resource to get adequate bereavement care for your families is really important, and they oftentimes will have somebody who manages that.
So our bereavement counselor here would help any of the local community hospitals if a child died there.
Absolutely.
With the family.
Oh, absolutely, and we get calls all the time for help and support. We follow our families for a minimum of 18 months here at Children's Hospital of Pittsburgh. We have regular contact with the family, Father's Day cards, Mother's Day cards. We send a card on the child's birthday. We call the family at regular intervals. We provide the family with a packet with community resources. If the family indicates an interest in mental health services, we find appropriate counselors and providers for them. It's a very comprehensive program. I'm not saying that every hospital needs that comprehensive of a program. It's obviously nice that we have that. But if you even want to provide basic bereavement support, contacting your nearest pediatric palliative care provider or your local hospice can be very helpful in finding those resources.
And what about organ donation?
Again, yeah, that's a really important question. Again, that varies state by state, and each state has their own separate laws regarding that. Here in the Commonwealth of Pennsylvania, what I can say is that we, as the providers, are not allowed to discuss organ donation unless you are a designated asker, and that means that you've worked with the Center for Organ Recovery to become a designated asker. We are mandated by law for every death to report that to the organ donation group here in Pennsylvania at the time when we feel death is imminent, and then again after the child has died. And it is up to them to determine if the child is a candidate, and it is up to them to contact the family. Many people believe it's a conflict of interest, and I would agree with this, that it's a conflict of interest for the treating physician to discuss withdrawal of artificial life-sustaining therapies, and then the next breath talk about organ donation. And so what I advise all of our physicians here in the hospital and our residents is that if a family says to you, we'd like to talk about organ donation, my response to that is, thank you so much for bringing that up. It's a very important topic. By law, I'm required to report this to our Center for Organ Donation and Recovery, and I will make that phone call, and if your child is eligible, they will contact you. I, as your physician, am not allowed to talk about that because my primary responsibility is to take care of your child. And so that just lets them know that, this is something that you support and are interested in helping them get the answers to, but that it's up to another entity to ask about that. And I would say that's probably true in most states.
I think you answered this. So there's one of the knowledge goals is identify local, regional, and national resources for pediatric palliative and hospice care. You talked about your local hospice group, calling your quaternary care, large children's hospital you referred to. Are there any national resources that physicians can use?
Absolutely. So the academic group that oversees hospice and palliative medicine in the country is called the American Academy of Hospice and Palliative Medicine, and that is affiliated with the Hospice and Palliative Nurses Association. So it's AAHPM and HPNA. You can find that resource online at www.aahpm.org. I will also say that the American Academy of Pediatrics has a section on hospice and palliative medicine, and they are a great resource and have advocated for hospice and palliative and end-of-life resources for children, just as they advocate for many other things for children. So also there's the National Hospice and Palliative Care Organization, nhpco.org, and they have a lot of online resources available to help you identify sources of support in your community.
Now, we have to talk about the Hospital Ethics Committee. So describe the role and composition of it and how it relates to patient and family caregiver decisions regarding end-of-life decisions.
It's really important, and I think every ethics committee probably performs different services in their hospital, and so we definitely have a relationship with our ethics committee. I would say that the majority of issues that come up from an ethical basis can be resolved by improved communication. And oftentimes our ethics consultants will tell us that with improved communication, we can remedy the situation. Sometimes you are truly stuck from an ethical conundrum, and the ethical principle that prevails in pediatrics is the best interest standard. And so ethical decisions should be made in the context of what is best for the patient. Obviously, that's in the eye of the beholder. The law typically gives that decision making to the parent. However, if caregivers believe the parents are asking for things that aren't ethically appropriate, then your ethics committee can really help you sort through that sort of thing. I will point out that the best interest standard is different from substituted judgment, which is what is used in the adult side. So if there's an adult who is on a ventilator and a decision needs to be made as to whether or not to continue that ventilator or withdraw that ventilator, the question to the healthcare proxy is, if so-and-so were here right now and able to tell us, what would they say? That's substituted judgment, and that works for adults. In pediatrics, it's the best interest. What is in the best interest of the child? Unfortunately, that is open to interpretation.
So who should be or is usually on these committees?
So oftentimes palliative care physicians serve on those committees. Usually it's a group of interested physicians, nurses, and social workers that participate in this, and some people from many other disciplines participate in these committees. I think it would be someone who has a sincere interest in ethics and also has some degree of training in ethics principles.
What can you describe any cases that have had broadly have had to go to the ethics committee?
I think there are the cases that tend to go to the ethics committee most often are cases where it's felt that there's medical futility in the case. So the parent may be asking for a treatment or continuation of a treatment that is no longer felt to be medically indicated or beneficial to the child, and that causes a lot of friction amongst the staff. And I will say that oftentimes in those cases we just need more time to get the parents to a place where they need to be, and hopefully we're involved enough that we can afford them that time. If we truly feel that the decisions are being made that are harmful to the child, then it's our obligation to speak with the attorneys and lawyers that help us out if we feel that the child's best interests aren't being met.
That brings in one of our skills, managing ethical dilemmas encountered in the inpatient setting. So if I've understood what you've said, a lot of it's good communication, giving the family a little more time, and if there's a significant ethical dilemma that you don't feel you can get a resolution to, the ethics committee can help.
Yes.
And then from there, it's the hospital lawyers and legal system.
Yeah, exactly.
Overall, we've kind of gone over all of the knowledge and most of the skills for the core competencies for pediatric hospital medicine on hospice and palliative care. The attitudes for those of you who are listening, I don't know how in any way that could be tested on a board examination, but creating awareness for the importance of pediatric hospice care. After this lecture, you should be able to do that, I think. Creating awareness and acceptance of palliative care approaches, which may include alternative and or complementary medical therapies, which does bring up one quick question. Have you guys used acupuncture, really alternative therapies?
Yeah, we actually did a research study using Reiki therapy, which the families responded to nicely. My view on alternative and complementary medical therapies is that as long as the child is not being harmed by it, as long as the parents aren't taking out a second mortgage on their house to complete it, and that it's not interfering with the other care that we're providing the child, that these things are completely reasonable and worth pursuing.
And then role modeling ethical behaviors, you should be able to do that on your own. And identifying gaps in personal knowledge, skills, and attitudes regarding palliative care and utilization opportunities for professional education to address them. Again, that's a personal issue. If you're a pediatric hospitalist and you know there are gaps, you listen to lectures like this, you go to lectures, and you talk to your hospice and palliative care person, and I'm assuming, Scott, these websites have some educational component
Absolutely.
hospitals can look at.
Yeah.
So to wrap up, I want to start by saying thank you to my guest, Scott Maurer. This has been the least I've ever talked in one of my podcasts, and I can't thank you enough for that. I really appreciate your time. Here, these are being rewritten, the core competencies. At some point, I believe they'll come out again, so we'll do this again in a year or two. We'll see. So thank you very much.
Wonderful. Thank you very much for having me. It's always a great opportunity to spread what we do.
And for acknowledgements, quickly, I want to thank the rest of my group for letting me do this. I want to thank the University of Pittsburgh for giving us the free CME credit to anyone who listens, and of course the Children's Hospital of Pittsburgh of UPMC. Finally, just as a reminder, if any of you want to get the free CME credit, please follow the link on whatever site it is that you downloaded this podcast, taking you directly to the HS Connect site at the University of Pittsburgh, where you just answer a couple questions that I've created and you get your free CME credit. Thank you again. And then I want to thank Dr. Megan Keene Tarchichi, who always helps me with everything. Thank you to everyone listening. I really appreciate it. I hope to see all of you at the Pediatric Hospital Medicine Conference in July in Nashville. Again, as always, if you have any suggestions or comments for the podcast or just want to shoot me an email, send me an email, Tony, Tony.Tarchichi, Tarchichi, @chp.edu. Thank you very much. You all have a nice day. I'll see. And for the next podcast, we're probably going to do a toxicology podcast based on the core competencies again, but we will see. It should be within 4 to 6 weeks, so expected by the end of June. Thank you very much. Bye.